All right, so our topic for today is the opportunistic prophylaxis therapies, and it's part of the basic HIV management program. You know, in our masterclass, we interface between the advanced conditions, like one of the topics we are going to be doing next week, but also some of the basic topics which we really need to deal with in our practice. But before I start, I just want to gauge, and assess if you can help me just to answer this basic question. How confident are you in initiating prophylaxis therapies for your patients? As you joined this session, did you feel that you are very competent? Did you feel that it's something new that you still need to learn? Or you are practicing, but you have a lot of questions, which I'm hoping, I'll be able to answer, for today. Great. Yes, so I see, yes, let's all practice because we are going to be doing some polling. So it's a good time to practice. Great stuff. So I'm going to stop right there and then show you that most of us believe that we are good. Very few believe that they are excellent. And you can see some are saying, no, I'm just average. And then some are saying, no, we are not that confident. So I'm hoping with the next poll, we will all participate. We usually put them up for 30 seconds. All right. So yeah, so let's then get on with it. So in terms of how we are going to approach this, we are going to start with the common things, cotrimoxazole, TB preventative treatments, and then fluconazole therapies. I want to encourage you to engage with me. I do check the chat and the Q&A, time and again, just to make sure that, I'm able to respond to some of your concerns and questions. And then there's other, because I want you to be aware that though when you read the South African HIV guidelines, we tend to talk about these first three prophylaxis therapies. There's other things that we need to consider. And if you're going to write the diploma as well, you need to know about that. I am going to switch off my video because I'm getting messages that some are struggling with network, and maybe the video would make your life easier. So towards the end of the session, during the Q&A, I will bring back the video and then we take it from there. So in terms of cotrimoxazole, really it is a drug that is common. We use it every day, even for other conditions, whether we are treating very, very minor infections or urinary tract infections. And it's a combination of two drugs, trimethoprim and sulfamethoxazole. And we use it really, for its great benefit. I was trying to come up and share with you a lot of data, but I realized that it's a program really that we have used for a number of years. What is very important is for us to appreciate the benefits of initiating cotrimoxazole for our patients, primarily to prevent pneumocystis jirovecii pneumonia, which is really a significant contributor, to morbidity and mortality. But also yesterday, I attended a meeting on the review on maternal deaths, and non-pregnancy related infections are continuing to contribute to maternal deaths, particularly TB and PCP, in pregnancy, or PJP as we call it. Last week, we dealt with patients who present with focal neurological lesions, and toxoplasmosis was a discussion point, which is also prevented by giving cotrimoxazole. Bacterial infections, specific diarrheas, Isospora baeyi, Cyclospora species. These are classified as WHO stage 4. So these are 8 defining conditions. So if a patient presents with diarrhea, and when you do your cultures, we pick up Isospora baeyi or Cyclospora, usually we say your patient has an AIDS defining condition. So really, cotrimoxazole will prevent this chronic, very difficult to treat watery diarrhea. And importantly, in the African context, it also has some benefit in preventing malaria. That's why in certain African regions, the eligibility criteria for cotrimoxazole goes up to a CD4 count of less than 500. and mainly is to get a dual benefit, to prevent specific HIV-associated opportunistic infections, but also to reduce the incidence of malaria in those particular countries. You won't be able to see this nicely, but I have put the reference and when we share the slides later on, you can then look at this particular article, and you can see the systematic review of a number of studies, and you can see that patients who are on cotrimoxazole with CD4 counts less than 350 have a significant reduction in mortality versus control groups who would have received, something else. In terms of progression to stage 3, stage 4, you can see that it was quite beneficial in terms of preventing PCP, malaria as well. For those with higher CD4 counts but not on ART, you can see still beneficial where there's reduced mortality, reduced hospitalization, reductions, in malaria, certain pneumonia, certain diarrheas, even some benefits in terms of TB. However, there is no study to confirm that if you give patients cotrimoxazole, you will reduce the incidence of TB. So overall, cotrimoxazole is quite crucial in preventing opportunistic infections, and we need to make sure that all patients who are eligible for this particular drug are initiated on it. And you can see in the South African guidelines, we have went back to say, let's initiate cotrimoxazole for patients who have a CD4 count that is less than 200 cells, or those who are clinically symptomatic. And here we'll be referring to your WHO stage 2, stage 3, stage 4 patients with HIV disease, including TB. So you have to make sure that if a patient is symptomatic, irrespective of the CD4 count. So if my CD4 count is 1,000, but I have oral candida, or I'm a pulmonary TB patient, I should be initiated on cotrimoxazole, which is quite important. The other key thing is the dosage, and sometimes when we do clinical audits, we find that there's a confusion. It is best that when you prescribe it as 960 milligrams, and we know that would mean that you have combined both concentrations of the two drugs, because sometimes if you write it in tablets, you say 2 tablets, and your pharmacy there, they have the double strength tablet, which is the 960. If you say 2 tablets, it's an overdose of some sort. And if you say 1 tablet in the context of a 480 milligram tablet, it will be an underdose as well. So it's best to prescribe it at 960 milligrams daily, so that if you have the double strength tablet, your patient will take 1 tablet. And if you have the single strength tablet, your patient will take 2 tablets as needed. And then where you have a patient who's experiencing some mild reaction or previous allergy to cotrimoxazole, it is best to consider dapsone 100 milligrams per day. Remember, some patients might still develop hypersensitivity to dapsone, especially if they had a very severe reaction to cotrimoxazole. So this is the eligibility, when to start, when to stop. And I'll just summarize it for you this way. All children, if you are looking at children less than 1 year of age, all HIV positive children less than 1 year should be started on cotrimoxazole, irrespective of their WHO staging or CD4 count, because we know that the PCP for that age group is quite a severe infection, and most babies would not survive, which is key. Now, once the child crosses 1 year to 5 years, we now consider the staging. So any HIV symptomatic child, or where the CD4 percentage is less than 25%, we should be starting them on cotrimoxazole. And as soon as they have improved immunologically with a CD4 count of above 25%, you may stop cotrimoxazole. However, the same kids, if you are dealing with a child who previously had a diagnosis of PJP, PCP, pneumonia, these children, we should never stop cotrimoxazole for at least until they cross over 5 years of age. So if you have a 4-year-old, 3-year-old, previous history of admission or treatment for PJP pneumonia, those children should remain on cotrimoxazole prophylaxis therapy, at least until the age of 5. And it can be reviewed thereafter, and then you're going to follow the adult program in deciding how to deal with this one. So for adults and children who are older than 5 years, you are going to review them, mainly looking at their CD4 count. So if you have an adult patient with a CD4 count of less than 200 cells or clinically symptomatic, they need to be initiated on cotrimoxazole. As soon as the CD4 count crosses 200 cells, that is the only time where you can then consider stopping cotrimoxazole at that point in time. I'm going to continue from here. Now, in terms of the next prophylaxis therapy, and I'm going to spend a little bit of time on this one, because I have my colleagues, who sometimes have a lot of questions. And maybe before I move there, I see Dr. Moody, you are asking, what do we give if a patient has an allergy to sulfur products? Dapsone can cause allergy. Does the alternate prevent all these conditions? Well, yeah, usually we use Dapsone, and really in the public sector, that's as far as we go. I know that in the first world countries, they do have, there's a drug they use which is inhaled at least once a month. I will get the name of that particular drug, but it's not something really in our setting that we use. So all we have is Dapsone. Otherwise, start your patient on ARVs. Let's hope they reconstitute and they have a higher CD4 count above 200, and then hopefully we win in that context. Yeah, so we will still deal with that question again after here. So thanks for that, Dr. Moody. Before I continue, I want to see if there's any additional comments as well about this one. All right. After completion of TB treatment, when do we give INH? Okay, Doreen, very, very important question. We're going to cover that now, right? So yes, so in terms of TB preventative treatment, it's quite important to note that it is the use of one or more of the TB drugs to prevent the incidence or the occurrence of TB. We usually give it to patients who have latent, and we emphasize latent because if someone has active TB disease, that is, they have symptoms, they might be coughing or night sweats, those kinds of patients are not eligible for latent TB treatments. And they are quite beneficial in that you get up to 64% reduction in new cases or in the risk of developing TB, particularly for patients who have a positive tuberculin skin test. Remember, a positive skin test only confirms that your patient has latent TB infection. And really, in the South African context, we sort of presume that we are all exposed, and therefore this particular test might not be needed. And up to 33% in patients where the TST test is not done. Someone might say, but 33% is a little bit, significant reduction from 64%. But remember, in South Africa, we get about 300,000 or so new TB cases on an annual basis. So when you say 33%, you are reducing that by 100,000 cases, which really would improve and give us some chance to also respond to that. So, and then the other thing to address is that there is no increased risk of INH resistance, because sometimes we are a bit hesitant, to provide TB preventative treatments because we are more worried about resistance and so on. So yeah, so this is something that we will deal with. So if you look at where the TB preventative treatments work, all in all, you'll find that as humans, whether in a car, in a movie, or in a workshop, you might be exposed to someone who's got TB. 30%, around 30% or so of people who become exposed become infected. And this is quite important. You know, exposure is not equal to infection. As you can see, about 70% of people would remain uninfected, which is quite key. Now, the 30% who became infected, around 10% or less would have immediate TB disease, which we call primary TB. And then if we are not able to timely identify them, they can then continue to spread it and infect more and more people, and the cycle is maintained. Our interest today, it is this 90 or 95% whom after becoming infected, they are able to contain the disease, right? And this TB is lying dormant there in the lungs, controlled by our immune cells. It is not replicating. These patients are not sick, and also they are not infectious, right? Very, very important. However, under certain conditions, these patients can then reactivate later in life. You know, if someone is a child, or you become HIV positive, you become diabetic, you know, or you work in a high-risk clinical setting. That's why health workers are regarded as high risk for developing active TB, right there. You know, and where TB preventative treatments work, it's exactly here. The whole theory around it is that if the majority of patients who are infected have this latent, dormant, non-replicating TB back in their lungs, can we treat it? Can we treat it before it reactivates, right? And really, that is how then we start to use some of our TB drugs to treat latent TB. Actually, it's no longer called a therapy. It's now called treatment for latent TB, with an aim of reducing the number of cases which eventually, you know, reactivate, which is quite key. And these are some of those studies published by the World Health Organization. And you can see we're looking at the impact of TB preventative treatments in people living with HIV and AIDS. And in this instance, these patients were done a tuberculin skin test, so exposure to TB was confirmed, right? In other words, those who had a negative TST results were excluded. You know, but you must remember, in the HIV context, the majority of our patients, if you do a TST, will have a negative one because they do not have enough immunity or immune response to your PPDs, you know, and so on. And what we see when you compare the two groups is that in the group that received TB preventative treatments, there was up to a 64% reduction in the risk of one, you know, developing TB. This is very huge considering the numbers of cases that we get in South Africa and what the actual implications are if we are able to, you know, increase coverage of TB preventative treatments for our patient. In this particular group, we are looking at the same study, but now they said regardless of the TST result, right? So whether, in other words, here a TST was not done. Whether one had a TST that's positive or not, it didn't matter. As long as you are HIV positive, you are given TB preventative treatment. And you can see up to, you know, 33% reduction in the risk of one developing TB. And this is what we are aiming for as we introduce latent TB treatments in this context. And to my dearest clinicians who are worried about resistance, really, there is no solid evidence. If you look at some of these studies, they are as old as the 1950s. INH prophylaxis is a very old program. And the way we are using it, you know, in the country, if there was a risk of resistance, we would have picked it up, you know, by now. So there is no any strong evidence to suggest that in a patient where active TB has been excluded and you provide INH prophylaxis, for example, that you are increasing the risk of resistance. We have not seen that. At the heart of access to TB preventative treatments is our ability to identify patients who might be having latent versus active TB disease. And this we do through, you know, a screening questionnaire most of the time. Are you coughing? Do you have night sweats? Do you have loss of appetite? Cough of any duration in HIV, is regarded as a positive screening outcome. So once you classify your patient to be having active disease, you mean that they are quite sick, they are symptomatic, they are infectious, and you even register them as a TB case. However, our patients whom we have screened and they are not coughing, no loss of weight, no night sweats, they are generally non-infectious, and they can actually be treated with TB preventative treatment. So we must be able to differentiate between these two groups. So how do we exclude active TB? Like I said, by using TB screening, but you'll see that for some patient populations, there's additional assessments that we need to do. Here we are looking at adults and a non-pregnant female. The only requirement as an entry point to TB preventative treatments is a TB symptom screening questionnaire. And if your patient has no symptoms and also they don't have any contraindications to some of the drugs that we use, they should be offered TB preventative treatments. In pregnancy, the story is a bit different. Number one, you want to screen all pregnant women and ensure that they don't have TB symptoms. However, negative TB symptoms in pregnancy is not enough. You also have to collect a sputum for TB gene expert, regardless of what you found on your symptoms, right? So if it's an HIV positive pregnant lady, you have screened her, irrespective of whether she's got symptoms or not, we need to collect sputum for a gene expert, right? And then in addition to that, you want to check their CD4 count. Now, this is quite important, right? Isoniazid preventative treatment is quite beneficial in pregnancy. I've already mentioned that TB is a leading cause of death in pregnancy. It continues to create a lot of problems for us. It is also quite difficult to treat. So preventing TB in pregnancy is an important program. However, the benefits of giving INH in pregnancy are more significant for women with lower CD4 counts. At the higher CD4 counts, the risk of bad obstetric outcomes becomes too huge than the benefits of giving INH. Therefore, as you will see in the guidelines, the recommendation now is that women with CD4 counts less than 350 must be offered TB preventative treatment, particularly INH. If she has a higher CD4 count, we defer the INH to at least 6 weeks post-delivery or during the postnatal phase of her pregnancy. Then that's when we can give that. So it's a risk, benefit balance more than anything. So in pregnancy, we need to meet all the three requirements. She must be asymptomatic, the gene expert must be negative, and she must have a CD4 count that is less than 350 if we are going to get the greatest benefit right there. All right. And this is the basic algorithm. A woman comes in, we screen her for TB symptoms. If she does have symptoms, she's a TB suspect or she's got presumptive TB, we then investigate. If she's got TB, we start her on TB. If TB is not confirmed, we are not going to rush to provide TB preventative treatments. We have a 3 months waiting period. And then if after 3 months we screen her and she has no contraindications to INH, we can offer her INH again, right? If you have screened again for TB, and the TB screening outcome is negative, we have to assess for contraindications, pre-existing liver disease being very important, alcohol abuse, previous hypersensitivity to isoniazid, and a high CD4 count in pregnancy. This would be your contraindication. So in other words, even if she's asymptomatic, but she has some of this, we might have to exclude our patient from accessing INH. However, if the symptom screening is negative, there are no contraindications, we should be able to start TB preventative treatment, INH for at least 12 months. And remember, there is no merit for us to do a TST skin test in South Africa because one, we do not have enough, we never had enough needles at that point in time. The PPD was always out of stock, if you remember when we tried. And then also the skill to inject it was a problem. And after injecting, patients must come back, within 3 days, 72 hours. We had a lot of loss to follow up scenarios. And then lastly as well, the response from our immunosuppressed patients was very poor. So half the time, even when it's negative, you sort of thought she probably needs INH. Therefore, we provided INH at that point in time, right? So that was, this is where we are. So someone asked, who is eligible? And then I want to cover just a few points around that. So in terms of your non-pregnant adults, all HIV non-pregnant adults, whether on ARVs or not, who have not completed IPT before and have no signs and symptoms of active TB. So in other words, we don't repeat IPT, it's very clear. And for your non-pregnant adults, whether they are on ARVs or not, we should be considering them for this. And then also we need to ensure that active TB has been excluded, right? In pregnancy, which I've already covered, all HIV positive pregnant women where the symptoms are negative, TB expert is negative, the CD4 count is less than 350, they are eligible. A patient who has completed TB treatment successfully can still benefit from INH. And how you approach these patients is that you have a patient who has completed TB treatment. You need to check, one, is your patient still symptomatic or not? Patient's symptoms have resolved. It's a green tick, right? Is your patient gaining weight? Yes, my patient is gaining weight, right? And then lastly, where possible, you would have repeated your smears. Your smear at the end of the treatment should be negative, and your patient, has completed or even has been cured, and then we are more happier. And there's a question always that says, so if someone completes TB treatment today, where can we start INH? We say as soon as you have confirmed these three things, that your patient's smears are negative, the symptoms have resolved, and your patient is gaining weight. There's no waiting time. And the rationale behind it is that we do know that our TB patients who are living with HIV tend to have a recurrence. They complete today, within 2 to 3 months, they are back. We assess them, we start them again, because after 6 months of treatment, some patients still have this residual dormant latent TB, which can reactivate in few months' time. That's why in other countries in the early days, they had considered treating TB patients living with HIV for a longer duration compared to your HIV negative patients. So that is the greatest benefit, to reduce the recurrence right there. So I hope you are still with me, so if you are still with me, do type in there, because sometimes when you teach virtually, you talk, and you are alone. So do let me know. I will still come back to some of your comments and questions as well. So quite great. I see in Tabi saying you are here. Great, Dr. Mnisi. Thank you. Yves, I'm happy to see that. And Dr. Simelani. All right, great stuff. I see that you are still here, which is great. Now, who is not eligible? I mean, this is now obvious. It's the opposite of the eligibility, right? Dr. Nkolela, good to see you. So, confirmed or suspected active TB, we exclude. Pregnant mom with a high CD4 count, she's not eligible, right? Active acute chronic liver disease, yes. Remember, pre-existing liver disease, hypersensitivity to INH, and someone who's being abused by alcohol. These are exclusion. This is our exclusion criteria right there. And yes, I see Mamello, you say you got it, asymptomatic, gaining weight, and negative smears. But remember, the third one is not always possible, because some patients at the end of the treatment, they don't have smears, or they were not even diagnosed with a smear. But as long as they have improved clinically, they could still benefit from INH right there. Right. So in terms of the dosing, once you have made your decision, it's 5 milligrams per kg. This is for adults. Remember, children metabolize this drug very fast, so their dosage is quite higher. We use 10 milligrams per kg for the children. So don't forget that. And then adherence and support. And because this is regarded as a prevention program, we do not want patients to experience side effects. So we monitor those side effects, and then we make timely decisions as needed. As soon as your patient has symptoms, you have to interrupt, investigate, and if TB is confirmed, we don't treat active TB with 1 or 2 drugs, right? Once it's active TB, we need to treat our patients with Rifa-4 right there. All right. Yes, and then for children, you will read the slides, but I will summarize it this way for you, right? And I want to do, and I've been saying I want to do an algorithm, because when I was teaching for national, I ended up drawing up an algorithm in one of the sessions there. So just remember, number 1, there is no routine IPT for children. Let's start there, right? There is no routine IPT for children. So that's where it starts. The first entry point for you to consider isoniazid preventative treatment in children, the first thing is that there must be an adult contact or an adult who has TB living with the child. If there is no contact, there is no IPT for children less than 15 years. So that is where it starts. If there is a contact, there is an adult who has TB living with the child, that's when you start to consider IPT. The next question, after confirming that there is a contact, the next question is the HIV status of this child, right? If the child's HIV status is positive, so all HIV positive children less than 15 years exposed to an adult who has TB, right? You would initiate isoniazid, 10 milligrams per kg, not for 12 months, but for 6 months. So there is no 12 months IPT for children. It's only for 6 months. I'm going to repeat it again. You have a child, HIV positive. There's an adult living with the child who has TB. So there's a positive TB contact, right? Very key. That child, as long as they are 15 years and below, they are eligible for isoniazid prophylaxis, and you would give it for 6 months, right? Now, let's come to HIV negative children. Again, there must be a contact. So there's an adult who has TB. You have a child whose status is negative. Children who are HIV negative who are less than 5 years are eligible for INH. If you have a 7-year-old who comes in, and this 7-year-old, there is a contact, but the child is HIV negative, that child is not eligible for INH, right? They would be eligible if the child was HIV positive, and that is really key. You can ask questions towards the end, and then we can try and engage with it and see how far we go on it, right? So, and then also you see the last bullet, remember with the adults, we said we don't repeat. I don't know if you remember, we don't repeat INH prophylaxis, but with children, we repeat with every exposure. So if there's a contact this year, you give. If next year now is the wife of the husband who's now having TB, the child must be reassessed and must receive INH prophylaxis right there, right? Thank you for all the questions. I see them, but I think I'm answering some of them as we go. And then towards the end, we will go through them slowly by God's grace. Now, I have a small scenario just to engage you a bit. We have a case here of Thabo. Thabo is a 25-year-old male who's on ART. You are screening Thabo for INH. When you screen someone for INH, what assessments do you need to do before? So you have some options. I know there's others. You might type them, but I'm interested in the ones you are looking at now. You may select more than one if you think more than one assessment needs to be done. But yeah, this should be interesting. Dr. Muriba, are you with me? I wonder if he has arrived. All right, great.
I'm here with you, Dr. Mawel.
Thank you, Doc, because I want you to take us through some of these assessments which are proposed here. All right, colleagues, it's 30 seconds. I'm going to stop and then show you the results. Dr. Mliba, what do you think of this feedback? Are you able to see it, Doc?
Yeah, I'm able to see.
Okay.
Yeah, so it shows that. Am I audible?
Yes, we can hear you. Thank you.
Yeah, I think the majority of people are using the TB screening tool in
Good.
terms of their assessment, and then smaller portion, I mean, still using sputum for the assessment of patient, and a small portion of people suggested liver function test, and and then also the review of other drugs the patient might be taking.
So are you happy with all these assessments, Doc? That's what I'm trying to get to. Dr. Mriba, I'm not sure, we can't hear you. All right, colleagues, I think we might have a net.
Sorry, it was muted, man. I'm sorry about that.
Okay, Doc.
Okay,
what's your quick feedback? Yes.
Yeah, am I audible now?
Yes, just quickly, Doc. Thanks.
Yeah, so remember in your presentation, in terms of for screening, we have a questionnaire that we use in terms of for patients, and then we use that for eligibility. Obviously, there are some exclusion, especially for the pregnant women. But here in this case, likely for us, it's a male who's 24 years old. So in terms of the assessment for our patients, we have to use our questionnaire, which has been proven to be more effective in terms of screening of our patients. So we need to make sure that we use that tool for that. It doesn't need to go to the lab. Likely doesn't need a patient to take a sputum in a room, or a patient to take some blood from the patient, or X-ray for them. It's just questions that it take even less than 5 minutes for that.
Yeah, so thanks for that, Doc. Yes, and I think that is the point. And I mean, obviously, as I ask some of these questions, it means I'm also trying to use, to test your knowledge. So TB screening, in terms of these assessments that are here, TB screening is at the heart of it. The second last one, the review of other drugs, very important, because we're trying to assess drug-drug interactions. However, a tuberculin skin test is not necessary. A sputum, unless if he was pregnant, you would be opting for that. A liver function test is not necessary. So quite important for us. I'm hoping you've managed to get that. Now, in terms of the follow-up there, let's see if you've managed to grasp contraindications to INH. Yes. Which of the following are contraindications for giving isoniazid prophylaxis therapy? Great. This one it's exciting. I think almost. All right, 5 more seconds, and then I will show you the results right there. All right, just on a quick note. Yes, you can see alcohol abuse, absolute contraindication. Pre-existing liver disease, absolute contraindication. Sensitivity to isoniazid, absolute contraindication. Dr. Mliba, what do you think of a CD4 count less than 350 in pregnancy? Doc, are you there? All right, I think today we have a network problem, so we'll continue. But yes, colleagues, remember, in pregnancy, the contraindication only if the CD4 count is above 350 cells. So quite important. So this third option would not be a contraindication in this context. But I'm happy that the majority of us managed to select the right one, right? And then lastly, now that the Thabo, you have assessed the contraindications and he qualifies for IPT, which of the following would be a correct regimen for a 25-year-old male patient? You can only choose one. All right. 5 more seconds. Yeah, all right. 2 more seconds. Okay, great stuff. All right, so here we are. The majority of us got it right. It's a INH 300 milligrams with pyridoxine for 12 months. The pyridoxine, we give it for the neuropathy, peripheral neuropathy. Remember, the first option there be correct for children less than 15 years, right? So if we had a child who is less than 15 years, then we would be talking about 6 months of INH calculated at 10 milligrams per kg. So I'm hoping that you got that right. All right, great stuff. Now I want to give you some highlights, right? In certain districts, and I've been the master trainer for that, in the country, we now have a better regimen. I'm not going to I can't teach you the details of it because there's just a lot, and we have a course on it as part of the platform. But yeah, we have what we call 3HP, the 3 there meaning 3 months worth of high dose INH and rifampicin, you know, and you can see there. So it's a combination of 2 drugs, isoniazid and rifampicin, taken once weekly for 3 months. I mean, this is magic. How do you shift from 12 months to 12 weeks? And this is not even taken daily. It is taken once per week. You only take 12 doses. And after that, you have the same benefit as what a patient would have received if they received INH alone for 12 months. So I just wanted to show you that there's innovation and there's better regimens. You know, this regimen is shorter, obviously, and it is also less toxic because it's taken once a week. Better adherence because it's 12 doses and patients are done. It has a high barrier to any form of resistance because we are using more than one drug. Similar efficacy to 12 months INH and other regimens. Less burden on the health system, you know, and it is safe as well to give with DTG and efavirenz. Like but I said, especially with DTG, you need to attend the course to understand how to initiate 3HP for patients who are on DTG. You know, there are some do's and don'ts, which are beyond what I'm trying to share with you for today. So there's a question, is 3HP better than INH? And the answer is yes, because if you look at the overall adverse event rate, it is 3HP has the lowest of all the possible TB preventative regimens. Even stopping because of adverse events, it has the lowest. Unfortunately, some patients do present with a flu-like syndrome, but again, when you look at liver toxicity, less than 1% really. So overall, it is a better, you know, drug. Does it have the same efficacy? Does it work? Do you get the same outcomes as INH? And as you can see, they're very, very, very comparable. You know, if you look at the cumulative, the number of TB cases, actually we had fewer TB cases from patients taking 3HP versus 9 months INH. And remember, in South Africa, we are not taking 9 months INH, we're taking 12 months INH. I thought I should share with you this magic combination. And what about 3HP in persons living with HIV? You know, does it improve the survival rates for your patient? And yes, you can see that 3HP patients survived better than other regimens. So really, it is that the drug, you know. What about in high burden settings where we have TB and HIV? as part of our programs is 3HP superior, and you see it is non-inferior. I mean, that is the correct language to use. So it is a combination of choice. It does have its own, drug-drug interactions, and for example, you can't use it in pregnancy. And for patients where TLD is the initiating ART regimen, you can only start it once you have a suppressed viral load. So quite a number of issues. Maybe in next month, I must come back and just deal with 3HP and give you the whole program so that you can understand it. But it's a snapshot really to you to say, there is better regimens in the country. It's not freely available in the public sector. There are pilot districts, in Mpumalanga, KZN, Gauteng, and then Eastern Cape as well. And I'm hoping that as we continue to train people, it will be a national rollout. And then Dr. Mori, you're asking, when I say high dose, it's 900 milligrams of INH dope once weekly, together with rifampicin 900 as well. And then I have showed you the data around the side effects, that it is quite better in terms of the side effect profile. Just to say that if you are a member of the platform, you are going to enjoy this 3HP course, which has 8 clinical points. I'm just sharing with you that as part of the TB month, all our clinical care platform members, you are going to have access to this program where you would learn everything about 3HP, how to dose it, how to stop it, what if a patient interrupts, why not in pregnancy, what are the drug-drug interactions with family planning, with malarial drugs, and all that, those kind of things are covered in that course. So if you're not a member, it's my call to you to say, hey, maybe become a member and start to enjoy all the benefits, right? So our last prophylaxis for the night, it's fluconazole prophylaxis therapy, which I think I keep on teaching about it, but you can never teach enough. It's always good to continue. So just to remind each other that crypto is a fungi that we find really in the environment, particularly contaminated soil. Usually we get it from dry bed droppings, but also from your eucalyptus trees. These fungal spores are inhaled similar to TB. They are trapped in our lungs. They lay dormant there, and there is no person-to-person spread. So it's not an infection which spreads, between people, but we all inhale it from the environment. The fungus can cause acute lung disease, but most of the time, you will only confirm this through serial cultures in a patient who's not responding to other treatments. Then you might think it's crypto if you continue to culture it in a sick patient. But most of us, we have a dormant, non-replicating fungi, and the incubation period is not known. You can have it for years and probably take it to the grave. Most patients would reactivate at CD4 counts less than 100. However, guidelines in the private sector have changed to talk about a CD4 count of less than 200. So yeah, so don't be confused. Sometimes you hear the private sector people talking about the testing even at high CD4 counts. And then meningitis is the commonest presentation. And at the high level, you have crypto, the different strains, you inhale it, then you have this latent infection lying dormant again in your lungs, then it can reactivate later on, and you first have this subclinical disease where you have crypto being detected in your bloodstream, right? And this is where we want to diagnose most of our patients with a serum or blood crack antigen. If it comes back positive, and we have excluded the meningitis, and we are able to treat easily at this point. However, we must remember this subclinical disease, if not treated, it progresses to a meningitis, and the meningitis generally has a very bad high mortality rate, as you can see, up to 70% mortality rate despite ARVs. Very important to know that ARVs have not improved the incidence of cryptococcal meningitis. So very, very, very important. In certain regions, it is believed that the crypto causes more deaths than TB. And you can see most infections happen here in the sub-Saharan region, where me and you stay and live. And you can see it is a significant contributor to deaths. And you can see probably more than TB as well in the sub-Saharan Africa. So quite an important infection for us to talk about. There's many ways to diagnose it. There's the Indian ink, there's the antigen, which is closer to becoming a molecular test, and then you've got your culture, but most of the time we are relying on the antigen test, and we call it a cryptococcus antigen test, or crack. Whenever you say, someone says, have you done a crack? They mean, have you made an effort to diagnose crypto with a crack, which is more sensitive and more specific than your microscopy through Indian ink. We do cultures in patients who have been treated and who are not getting better, and we want to see if they might be having a very bad resistant bug right there. So why is it important to prevent meningitis? Because in our context, patients with CD4 counts less than 100 are at a higher risk. The majority of cases, happen before starting ART, However, we do have patients whom we start on ARVs and then they come back with significant headaches, signs and symptoms, of meningitis, and which is a bit too late with very bad outcomes. So the idea is to identify patients before they even have a meningitis. I also want you to pay attention that on average, your crack antigen test can be detected on average or on a median of 22 days before the meningitis develops. And this is important because sometimes we think this is like a tuberculosis skin test kind of a thing. No, patients who have a positive crack antigen in the blood, they have an infection in the blood which has disseminated. In the next few days, it will become, a meningitis, especially if we fail to detect it and start appropriate treatment, which is quite key. So the cryptococcal screening program is where we need to identify patients who are at high risk, and the risk defined by a low CD4 count, less than 100 in the public sector and less than 200 cells in the private sector. These patients must be tested for a cryptococcal antigen test in the blood. If the test comes back positive, we treat with high dose fluconazole. We refer all these patients for a lumbar puncture so that we can exclude a meningitis, because remember, if the patient has a meningitis, the treatment is totally different. Then we prevent. The idea is to identify our patients who have a positive crack antigen before they get a meningitis, and we can interrupt the progression by offering appropriate fluconazole prophylaxis treatment at that point in time. If you haven't seen the results, this is how they look. You have a cryptococcal antigen test that is positive, and you can see it was done on a patient who's got a CD4 count of 8, right? It's a time bomb. This patient is not well, and then this type of patients we need to track. And in the public sector, and now I hear some private labs as well, this is done as a reflex test. That means you only order your baseline CD4 count. The results, when they come back, if the CD4 count is less than 100, your crack antigen will be done automatically. It saddens me that sometimes we fail to trace these results. I mean, we had a number of maternal deaths from women who booked early, who were HIV positive with low CD4 counts, crack test done automatically, positive, but no one checked the results. And then in the 3rd trimester, she gets bad headaches, she becomes sick, and then we fail to save her, in pregnancy. And then when we look back 6 months ago, someone missed a positive crack antigen. And if we had intervened at this point, we would have averted a maternal death. So this is quite a very bad infection, and we need to take it and give it the seriousness it deserves. And you can see Meyer et al. Here showing that in HIV positive patients who do not have symptoms but have a positive crack antigen, and you start them on ARVs, if you do not identify these patients and give them fluconazole, you are going to have a high mortality rate. You can see here, this is the widest gap I've ever seen in a survival curve, showing that it's important to identify HIV positive patients who have a positive crack, especially if you start them on ARVs. We have to check those crack results. And if the antigen test is positive, we must offer fluconazole because it improves their survival right there. So very, very, very key. Another key change is this one based on these similar studies as this. This is from Johannesburg, where they looked at patients with low CD4 counts who had a positive crack, where a lumbar puncture was done. And what you see, very important there, is that a lumbar puncture was done in 90 patients who did not have symptoms. Remember, the old protocol would have said, only do a lumbar puncture if the patient is symptomatic, right? But now we are saying there is a proportion, around 34% of patients who were asymptomatic, who had a positive crack, where we could have just treated with fluconazole only in the previous protocol, right? And we would have missed the fact that these patients have a meningitis because 34% of them also had the positive crack antigen in the CSF as you look at it there, right? This has changed the algorithm for fluconazole prophylaxis therapy to require that all patients who have a positive crack, whether they are symptomatic or not, they should receive a lumbar puncture. And this is in pursuit of identifying all those who might be having a positive crack antigen in the CSF, who then need to be treated as a meningitis and not as a prophylaxis. And here is the algorithm as we near the end. It says, for all HIV positive patients with a low CD4 count, perform a crack antigen test. That's where it starts. If the test is negative, we don't have issues. You can start ARVs, there are no problems. If the test is positive, all those with a positive crack must be referred for a lumbar puncture, whether they have symptoms of meningitis or not. If the lumbar puncture results come back negative, you can then start fluconazole 1,200 milligrams for 2 weeks. After 2 weeks, you can reduce the dose to 800 milligrams for 2 months. After 2 months, you can reduce the dose to 200 milligrams daily for at least a year. It should not be stopped until a patient has a high CD4 count, higher than 200, and the viral load is suppressed. So that is a very key right there. If the lumbar puncture comes back positive, we know that this patient has a meningitis. They must be admitted, treated with 2 drugs, amphotericin B and fluconazole for at least 2 weeks, then discharged on the consolidated phase. When we talk about opportunistic prophylaxis therapies, we are talking about an HIV positive patient whose crack antigen is positive, right? And the CSF crack is negative. We want to treat this serum positive crack and prevent a meningitis by prescribing high dose fluconazole, as you see, the 1,200 milligrams daily for at least 2 weeks. Then you continue with 800 milligrams for 2 months, then 200 milligrams for at least a year. There is an important note there from the guidelines, right? That if there is a delay in performing this lumbar puncture here, don't delay starting the fluconazole. In other words, if your serum blood crack antigen is positive, you might as well start fluconazole 1,200 milligrams as you refer your patient for a lumbar puncture. Don't delay the start of the prophylaxis because you are waiting for a lumbar puncture. Maybe it's a clinic that's very far. In the meantime, start your patient on fluconazole. So that is quite important right there. So I hope this algorithm makes sense. Do share your concerns about it, and then we will engage. But as we do that, is that time again where we engage and I see if we are together. So here is Mr. X. Hey, today they are all 25 years old. They are all male, right? You are seeing here at your clinic there. And here the baseline test. The CD4 count is 20. The crack antigen is positive. And he has no symptoms of meningitis. The first question to you is, would you do a lumbar puncture? That is the first question there. Would you do a lumbar puncture? All right, 3 more seconds. Okay. Okay, I'm gonna stop. We just will give you a few seconds. I'm sorry if some of you can't participate. You have crossed more than 80 for today, so yeah. All right, so here we share, and you can see that most of us believe that yes, and the answer is yes. That is the first change in the guidelines. All patients with a positive crack antigen must be referred for a lumbar puncture, though you don't have to delay the start of treatment if you think the lumbar puncture is going to be done a bit delayed right there, right? Then if the lumbar puncture crack antigen is positive, so your lumbar puncture results are back and they are positive, which of these would be the right option as part of your plan? Look at it carefully. No, I'm happy. I thought, I was talking alone. I think most of you were up with me, but I see some are still struggling a bit. But yeah, so yes, I mean, to be honest, it depends where you are, isn't it? If you are in a hospital, you start amphotericin B and fluconazole, which is that last option. If you are in a clinic far from a hospital, you start fluconazole 1,200 milligrams and refer. The problem with the second option is the dose. The 800 milligrams is the old dose, right? Now we'll use high dose, fungicidal dose is 1,200 milligrams. So that is quite important. The first one says review in a week. You can't send a patient who's got the meningitis home. So that is really the message. All right, so the last scenario, his LP crack results are negative, right? So now we are dealing with the serum crack is positive, the lumbar puncture results are negative. What is your plan right there? What is your plan? Look at it carefully. Don't be in a rush. Yes. Don't be in a rush. Some are tricky. 5 more seconds. All right. Great stuff. Great stuff. I'm going to stop and share with you. And yes, the crack results are negative. So the last one there is the best option. Start fluconazole 1,200 milligrams for 2 weeks. After 2 weeks, you reduce it to 800 milligrams for 2 months. After 2 months, you then take it to 200 milligrams for at least a year, and only stop when the CD4 count is above 200 and the viral load is suppressed. And that is where we are at. So I'm quite happy with you in terms of where we are, and this is the algorithm right there. Just to remind you, we were on the prophylaxis wing there, 1,200 for 2 weeks, 800 milligrams for 2 months, and then 200 milligrams for at least a year. Remember, the ARVs, you would only start them once your patient has completed the high dose, right? When you reduce it to 800, you might as well start ARVs. Quite important to note right there. And then the other is just 2 slides, just to give you a glimpse to say, when we say prophylaxis, we are talking about prevention of opportunistic infections. And we don't just prevent by giving antifungals and antibiotics. There's also vaccines, which can really benefit our clients. But I need you to be aware, the diplomats who are going to write, when you are asked about vaccines, we generally want to avoid live vaccines, generally. So there are alternate non-live or vaccines. But if you look at the live attenuated influenza vaccine, it is generally not recommended at any CD4 count for HIV positive patients. If you have a patient with significant immune depletion or uncontrolled HIV, you need to be very careful about some of these live vaccines: measles, mumps, rubella, varicella, yellow fever. In the EPI program of the country, we do give measles and everything, but you can see this is based on the American, guidelines. And at the high level, I just need you to appreciate that vaccines generally recommended, but you need to be very careful with the live vaccine. I mean, we used to see a lot of BCGitis. You give a newborn who's infected intrauterine from their mom. They are born immunocompromised. You give them BCG, they come back with a huge swollen arm and sometimes disseminated BCG because of a significant immune depletion. So you have to really pay attention. And these ones generally recommended, hepatitis A, B, meningococcus, pneumococcal vaccine, very, very important in preventing pneumonias and the meningitis as well. And then COVID-19 recommended in HIV, and don't forget other screening programs, for example, your pap smears, which can prevent HPV-associated problems as well. So just note that particular slide, and they've also made a very nice summary where they've listed. Unfortunately, I see my slide is cutting a bit. Let me see if I can help you and try and push my graph a bit low for you. Just give me a few seconds. If I can get it right, I'd be very happy there. Few seconds, I think. Yes, I need you to see it this way. Let me see. Great stuff. Yeah. So they have a very nice slide, this particular slide, which I like. What they've done, they've put different, medical conditions, pregnancy, patients who are immunocompromised, but not due to HIV, those who are HIV infected based on whether they have significant immune depletion or not, all sorts of conditions, and you'll get it with the slides, and you can see those live vaccines generally contraindicated: measles, varicella, zoster vaccines, so different vaccines by medical condition, and you can see the color coding there to say which ones are recommended, which ones you need to be very careful by medical condition. So very important to know that in addition to the use of Bactrim, INH, and cotrimoxazole, and fluconazole, there's vaccines, especially your pneumococcal vaccines, which can really benefit our patients. Your COVID vaccine as well, and pap smears and other things which we can give our patients. Right? Yeah. So all in all, I hope this session was really, worth your time. I just want to ask you this question again, then I'm going to go through your questions. How confident are you now? How confident are you after this workshop? Do you think you still need to go through more workshops, or you think your knowledge is a bit improved and you feel a bit better? Great. All right. Great stuff. Yeah, I won't play it that long. But if you remember the first one, we had a lot of I'm not confident, I'm average, but now we have a lot of excellent people. So it's a good sign. If you still need to improve your confidence, please do the basic HIV management course, which would really help you to study this, slowly. As well, become a member, because we share the recordings and you can watch this recording at your own self-paced time. Yeah, so that is today's topic. I don't know, I feel quite happy today. So let me go through some of your questions, and then before I take your hands, just quickly, let me go to the chat first and see what we have. Yes, okay, Masabata, you are saying if a child of maybe less than 5 years started on TB treatment at the clinic based on the TST, can it be stopped or continued? Yeah, Masabata, few rules about TB. If TB treatment is started, we don't generally stop it. We prefer that it must be completed, irrespective of what your second thoughts are after you have started. And a positive TST in a child less than 5 years, you know, there's that high probability that the child has TB. So if there's a TB contact, the TST is positive, the child has symptoms of TB, whether failure to thrive and so on, most likely they have it, but not the TST on its own, because a TST only tells us about the exposure to TB. Doreen, you are saying if a sputum is unavailable in a pregnant woman, what do we do? Yes, thanks for that question. You induce. You induce, involve the physio. They can also teach you how to percuss. You can also nebulize with the normal saline because it's a hypertonic solution. It will activate these droplet cells to produce sputums and allow your patient to cough. I know in the modern world, there's also ultrasound nebulizers and stuff, but yeah, you will try to induce it. That's what you would do. Let me scroll down there. What are the possibilities of the patient on TPT contracting TB? It's still there, Joshua. TPT is not absolute, and actually, when you do the program slowly, we talk about risk reduction, not necessarily that you are eliminating the chances of getting TB. HIV negative patients, if you're HIV negative, you have a 10% lifetime risk. So from birth to death, you have a 10% lifetime risk. If you are HIV positive, you have a 10% per year risk. So basically, we are reducing that risk to a normal risk. So the chances are still there. So you have to continue to screen your patients, and then you take it from there. Gaylord, you are saying, have you encountered a patient presenting with INH hypersensitivity? And what is, yes, they are there, especially the rash, you know, patients who present Steven Johnson, even with cotrimoxazole, you get the same. So with INH, I've already shared with you that you have 3-HP, but 3-HP has a high dose INH. So actually you don't have any choice, isn't it? Because even with the pediatric rifampicin, it's rifampicin with INH. So otherwise, your goal will be to start ARVs and help your patient to become competent. So there's no alternate to INH. Yeah, there's no regimen without INH. Yes, Yves, does it mean if a patient is on INH, he must also take pyridoxine? Yes, because INH, most patients will have some peripheral neuropathy. So this pyridoxine, 25 milligrams, is given as a prevention. And even when they have peripheral neuropathy, you can increase the dose, you know, to 50 milligrams, 75 milligrams, but also exclude other causes, you know, alcohol abuse, vitamin deficiencies, B12, you know, diabetes. So quite important. What are the possibilities of one TB preventative treatment not contracting TB? Well, I said it reduces the risk by up to 64%. So the chances of getting TB are still there. Dr. Modi, I think I've answered your question. High dose INH, yes. And then in the training program, we have a section dealing with those side effects from high dose INH, you know, which we will deal with. Joshua, as prisons are always overcrowded, INH is given to HIV for as long as they're in prison. We don't stop as there is, yeah. So are you working in the correctional centers? So yes, that is true. If you're HIV positive and you are admitted in a congregated setting like a prison, even in the mining sector as well, there's such programs. You'll be on INH the longest, but you need to know the side effects, especially for males. Gynecomastia is a huge problem, sometimes liver toxicity, you know, but you will deal with it as it comes. There is no standard monitoring required. Mpongo, you are saying this 1,200 milligrams of fluconazole is this applied? Yes, it's a primary healthcare program. But I know certain districts in the country, there's pushbacks from pharmacy, but it's an EDL, it's an essential drug list program, which you should be able to deal with. Dr. Modi, you are saying some patients never reach a CD4 count. Yes, so they should be kept on it, Dr. Modi. If we follow the guidelines, I don't want to encourage any alternate option. We know what a recurrence can do to these patients. Mbongo, I'm asking this question because you find clinics formulary having fluconazole 50, and I'm worried. Yeah, so this is a donated stock. The maximum tablet strength is 200 milligrams. So when you give 1,200, you give 6 tablets of the 200 milligrams. And I hope that is fine. I would like to discuss something. Okay, Dr. Shakes, we can discuss. He's my colleague from Right to Care. We work together there. So yeah, we can talk, no problem, Dr. Shakes. Yes. Tembela, thank you. There's never a dull moment. Oh, you are happy. Thanks, Tembela. If you're happy, I'm happy. Now you are saying currently it is recommended that we do a same test and treat. Yeah, I was waiting for that question, because if you test Dr. Mawela today and he tests positive today and you start him on ARVs today, and you do the baseline tests and you review them in 7 days and the crack antigen is positive, what do? You just start your fluconazole and monitor Dr. Mawela very closely. Don't stop the ART. There's no evidence to support stopping or continuing, but it's just a clinical best practice to say, if the patient is already on ART at the time when you get your crack antigen, start fluconazole, monitor your patient closely, especially for liver toxicity, and then you see if your patient is coping. Dr. Ngolela, but in COVID settings, induction of SWITAB is not allowed. Yeah, it's not, but we have to do it because otherwise TB becomes the problem. So you'll have to make your own assessment, and I think I understand your concern there, Dr. Ngolela. Sipiwe, WHO stage 3 CD4 count above 200, do you give Bactrim? Yes. If Dr. Mawela has a CD4 count of 5,000, way above 2,000, but Dr. Mawela has oral candida, or he has lost more than 10% of his weight, or he's got TB, he should be on cotrimoxazole prophylaxis. Thanks for that, Sipiwe. Someone says, hey, you are keeping them flowing today. Hey. Someone says, I have a client that was failing TEE, then was referred to hospital. So he came back with a script on TLD and abacavir, lamivudine, INH, and pyridoxine. Can we stop giving INH since it's 1 year? Yeah, if he has taken INH for more than 1 year, you should stop. You should stop. INH should not be taken for more than 12 months. I'm just worried about this thing of failing, and then now the patient is on abacavir and DTG. You know, that is what, actually in that case, I'm not worried about the stopping of INH. I'm worried about the poor DTG and the fact that the patient is actually on monotherapy. So do send me a WhatsApp and then let's discuss that case on the sideline. Yeah. Yes. You are saying the 2019 guidelines recommend the crack antigen when the CD4 count is less than 200. Anna, I think that's private. That is the HIV Clinician Society. I don't think the HIV guidelines have went to 200 yet in the public sector. So we take it from there. Dr. Ngolela, 3HP is not the same as RH. Now, RH has rifampicin. Rifampicin. 3HP has rifampicin. They are both rifamycins, you know, but they're a little bit different. So yeah, so an RH there's a regimen for TB preventative treatment using RH, as you have put it, rifampicin, and INH. It's a pediatric regimen. But what I'm talking about is 3HP, it's rifampicin. So these are, they sound the same, but a bit different, right? How do you manage an adult patient who's got a low CD4 count, the crack is positive, who's got a cryptococcal meningitis and hepatitis? You start with the crypto always. You always start with the crypto. You treat it for 2 weeks. After you have treated the crypto for 2 weeks, you start your ARVs. Because your patient has hepatitis B, your regimen should have tenofovir and lamivudine in that regimen. Your patient will do better, and better. You are asking there, Dr. Ngolela, if I don't have AMFO, what do I do? Well, there's a better drug. When we do the topic on crypto, we'll come on it. There's we call it 5-FC, 5-flucytosine. But it's supposed to be an option to replace fluconazole, you know. So ideally, you want to give 5-flucytosine with amphotericin B. I will start that patient on a high dose amphotericin, high dose fluconazole or 5-flucytosine, and really call all the hospitals and get that amphotericin B. Crypto is not supposed to be treated with one drug. Otherwise, you get the treatment failure and your patients don't do well. Gloria, you are saying, my first time here, and I'm grateful to have an opportunity to learn. Thanks, Gloria. Yeah, that's what we are aiming to achieve. But yeah, I'm hoping this is worth your time as well. Just some few questions. We still have a few seconds, guys. Don't go yet. Just to go through the last 2 questions. Dr. Mnisi, you wanted to confirm for an asymptomatic child less than 5 years with a positive tuberculin skin test, do we initiate? No, because your child does not have TB symptoms. So we don't initiate TB treatment. That one, Dr. Mnisi, you would treat with INH. But remember, for you to treat with INH only, there must be a TB contact. So you have a child less than 5 years, there is a TB contact, the child is asymptomatic, then you would treat with INH and INH only. Remember, you treat for TB if your child has symptoms of TB. So that is quite important, right? Yeah, so I want to stop here and just to thank everyone really for attending and for your continued support.